First, thank you for the invitation, and I will share some of the experience about when the mitral TEER is unsuitable. So these are my disclosures, and we know now it's very clear that the etiology of the mitral regurgitation is divided between primary and secondary. The primary, where there is flare, leaflet, or rupture, papillary muscle. All the problem is in the leaflet itself, whereas the secondary mitral regurgitation, the problem lies is in the annulus or in the left ventricle or the left atrium. And when to go for the mitral valve TEER, it's more clear now whether it is a primary or secondary. Those with inoperable or higher surgical risk, maybe they should go for the mitral TEER, or if for the secondary mitral regurgitation, if those fulfilling the criteria of the co-opt-like trial, we prefer to go for the TEER. However, even in non-co-opt-like, still the TEER, the mitral valve TEER is an option, but with less expected result. Now, although the title of the talk is suitable versus unsuitable, but in reality, this is maybe difficult to apply. I like to use favorable versus unfavorable label, because you would like to be in the left side of this table where the criteria or the anatomy of the mitral valve are more favorable for TEER. But if you that will be difficult to find such a patient all the time. But with your experience, you might be able to go toward the right of the table. And so even if those non-favorable, still if you have the experience, you might be able to do these cases. Now, as I said, everybody would like to have these cases, like a favorable anatomy where there is a central pathology with no calcification, a large mitral valve area with a good size mitral valve leaflet, posterior mitral valve leaflet with the tenting height suitable, flail gap is also not that large, and the width of the gap is also is not that large. This will give you an excellent result from severe mitral regurgitation to almost zero mitral regurgitation even with one device. However, as you move, as I said, toward the right, the complexity of the procedure will be more. So like in the previous session, the indentation of the posterior leaflet has been always a challenging anatomy to solve, because if you go to that indentation, simply you will open the mitral valve, the mitral regurgitation more. And if you put a device beside that indentation, it will not solve the problem. So maybe changing the strategy using two devices with A shape, like in the previous session was presented, is the solution to give an optimal result. Now, sorry.
شوف الليفت كورنر.
There's always this, I don't know why.
حط الليفت كورنر على الكرسر.
Sorry?
الليفت كورنر شوف إذا يحركك. Yep.
No.
Could we have some technical support here, please?
No, this is not the
Go
slide.
backward. شوف إذا يمديك to go backward.
Okay. I'll do it from my side if you don't mind. So another difficult situation when you have a very wide gap involving the whole mitral valve. with no coaptation at all. The MR is throughout the coaptation line. This might also be a challenging case to start with. But again, you might try to do the mitral TEER with less optimal result, and if the gradient doesn't allow you, then you have to stop there, and with less, you have to accept this result. And a very frequent challenging anatomy is the short posterior mitral valve leaflet. The shorter the posterior mitral valve leaflet, the more difficult to grasp and less optimally the result. However, it's possible, especially with expert hands from the interventional side. But if it is very short, like here in the range of 5 millimeter, you might not try it, and you might accept that to stop there and don't try to grasp it, especially if you are just starting up your program for mitral valve TEER. Sorry for the mix-up for the slide, but I would say the rheumatic mitral valve is the most, let's say, complex or not suitable for the mitral valve TEER, because simply you have a high gradient, a small area, and diffused commissure. So if you use the TEER for treating this type of patient, you will have higher gradient, you will have low mitral valve area post-procedure, so probably not to try the TEER, although I have seen a couple of cases that it was done, but you have to select your patient carefully. Again, sorry for that technical.
Seems you have heavy and good cases. Even the presentation could not handle it.
Yes, it crashed down.
Very much.
I don't know. Restart, maybe. Okay. Yeah. Okay. No problem.
So while waiting for it, Dr. Zakariya, a quick question. We talked about the gradient, the area. It's like, and you said like some cases you have stopped, and is there like a cut limit intraoperatively or intraprocedurally to acceptable gradient you go with based on either functional or degenerative, or like, let's say, primary or secondary?
You mean before or after?
Intra.
I mean, before the
deployment, let's say. You're doing the procedure, you accept it.
Okay.
So just because we're talking, because you said some expert can do it. So.
From the data that the gradient of something like around 5, both, the device, clipping is acceptable, but some, they might accept more gradient. The area before the procedure, if it is less than 3, I wouldn't try it. Maybe 3.5, we have done some of the cases, but 3,
so you draw the line at 3?
Because you are expecting a reduction of maybe around 50% of the mitral valve area post-clipping. So if you start with 3, that means you are reaching to the limit of severe mitral stenosis of 1.5 if we take this 50% roughly estimation of reduction of the mitral valve area.
Okay.
Yeah.
So your slides are up?
Okay, so another challenge is the severe mitral annular calcification. So especially if it is horseshoe-like and it's involving the leaflet, then this might put a risk of high gradient, low mitral valve area, and also you are putting a lot of tension in the posterior mitral valve leaflet, and you are risking injury to that leaflet or tear in the posterior mitral valve leaflet. So, as we said just now, that smaller mitral valve area also might limit the intervention because simply you are reducing the mitral valve area by 50% post-TEER, and the cut limit of 3 to start with might be reasonable. We have done something like 3.5 with acceptable result, but you have to select your patient carefully. As I said, it will put if you start with small mitral valve area, you might have higher gradient, and like in this case, we opted to stop the procedure and remove the device, not to deploy it because of this high gradient. So, going back to this table, so as you go more toward the right, you will have more complex anatomy. Maybe it is done, but with careful selection and with more experience, you will be able to do it. So take-home message, mitral valve complex anatomy, you have to look for every, details in the anatomy of the mitral valve, the leaflet, the area, the annulus, and the posterior mitral valve leaflet length, and also the calcification. Careful selection of the patient with more favorable anatomy, you have a better result, and more experience is needed to have to do more complex anatomy. These are challenges we are facing, but don't limit your challenges, challenge your limits. Thank you.
Thank you, Dr. Zakariya.